So I think neonatal spine is kind of an interesting topic just because it's different than a lot of the things that we've covered in our previous session. So, things we've talked about, acute scrotal pain or acute abdominal pain, where ultrasound is really the, primary imaging modality where we really can make the diagnosis. Spine ultrasound, I personally look at as more of a screening tool. So I think that, we really try to shunt these patients into, who can be watched without any further imaging and who really needs an MRI. So that's really kind of how I think about the main utility of spine ultrasound. So that being said, what I really want to focus on today is really just talking about some of the nuances of how we do these exams. So talk about some protocol tips and just kind of having a discussion about some of the things as far as that goes. And then also just kind of thinking about, like I said, some of the nuance of how we think about spine ultrasound. I think there's some, we'll talk about, Conus position, filar thickening, all those types of things that I think there's not necessarily universal agreement on, but really can affect how we think about these patients who might need further imaging. So the first thing in that regard that we'll talk about is the age limit for these examinations. So I have a couple of example CT images on the screen here. So this is the patient just a couple weeks old. So we can see we have this unossified cartilage in the posterior elements. Really gives us a nice sonographic window to be able to look at the spine. This is a patient that's about 6 months old that you can see there's starting to get ossification in the posterior elements, which can definitely limit our sonographic window. So my first kind of topic of discussion for Judy and Haitui is what is your kind of institutional age limit for these examinations? So what do you have kind of a hard cutoff, or how do you approach that topic, that component of this?
So in the ACR practice parameters, I think it says 6 months. That may be changed in the most recent update, but we have not found a whole lot of success after 4 months of age. So in general, unless it's a premature kid, we use more 4 months of age as the cutoff. Although if, occasionally there will be a scheduling delay. So if the request is ordered or scheduled a couple weeks in advance, and then the patient turns a certain age, we will still try to do those, mostly to look at the conus position, not look for like tiny little details.
Yeah, I think our experience is similar too. And there is a cutoff around 4 or 5 months. And if there's anything beyond that, sometimes we'll get like a specific email. And personally, I say, why not try? Because a lot of the times it's normal anyways. And so instead of subjecting the patient to an MR, but I guess you can argue that, if it's non-diagnostic, then you would have to go to MR anyways. But then in those cases, we try not to bill for the ultrasound.
Yeah, we're very similar to you, Haitui. I look at ultrasound as, a cheap, readily available tool. If it's non-diagnostic, it's just really no harm done to the patient. Likewise, we try to not bill for those. I've done a couple where I think, it definitely depends on the degree of clinical suspicion. We do have an age limit of 6 months, like the AIUM guidelines recommend, but very similar. It gets really difficult after about 4 months. We've had a few patients that had been older, on the older side, 7 or 8 months, and we've gotten a call, somebody said I have really low clinical suspicion. If I can at least see where the conus is, that'll be all I need. I don't need to do an MRI. I have a clear discussion with them and say, it's very likely we'll be limited. We might get some very limited information about the conus. If that's all you need, then we might be able to tell you that. But once you hit 6 months is where we kind of have less success with those feed and sleep MRIs. So we start talking about having to do sedation. So I really try to offer ultrasound as a possibility wherever I can. But like we said, I think it really is limited in a lot of those cases. This is kind of an example of that. So this is a 5-month-old. So this is our panoramic image. You can tell it's very, very limited. I can't really see much, especially down in the kind of lower lumbar spine and sacrum. I think at least counting from the ribs, we got maybe an idea of where the conus was at about the level of L2. But this patient had a higher degree of clinical suspicion, so went on to have an MRI. So you can see there's this filar thickening, this kind of filar lipoma. So we would never have been able to see this on ultrasound. So I think this is just an example, just kind of highlighting the risk of missing some of these things. But I think just having a very clear discussion with the clinicians and making sure they're aware of the limitations of what we could potentially not be able to tell them. And like in this case, things we certainly could miss. But yeah. So next topic about kind of protocol approach is spine numbering. So this is some of the different things that, like we said, that the AIUM kind of guideline talks about using for spine numbering. I just wanted to have a brief discussion on this, kind of which one of these you prefer, which one you kind of rely on the most, which ones you don't consider as reliable. What is your general approach to kind of figuring out where the conus is?
I think our protocol has both. So we count from below and above just to kind of make sure it's congruent, because as we know from just looking at lumbar spines and, chest radiographs, there's always like variability in like the ribs and thoracic vertebral bodies and stuff like that. So we try both.
I tweed, you go from like the thoracic spine level down, or what do you mean from above?
Oh, sorry, just from like the last few ribs.
Oh, okay. Yeah.
Yeah,
Oh,
yeah.
we do
So
that.
then
We do the same thing. We do both.
Yeah, no, we go from the spine.
Yeah, I'm like, oh God. What do you do when there's discordance between numbering from ribs versus like the lumbosacral, like, prominence or whatever?
Yeah, that's a tough one. I sometimes just like report both. And then I guess in those cases, if it's really like, if it makes a difference, like if I feel like the conus falls normal, regardless of whichever counting, then, I'm kind of done there. But if there's like a suspicion that maybe it's a little too low, and then that's when maybe, any kind of like follow up, perhaps even like the BB on the radiographs to kind of see where it truly is.
Yeah, we're very similar. Thankfully, a lot of the times when they are discordant, like Hattori said, the counting from the rib might be at L1, L2, and the counting from below might be at L2, L3. So if it's normally either way, I generally don't worry about it. I personally put more weight on the lumbosacral junction. If I can easily see where that is, I generally will go from that. The rib that kind of uses the secondary, I feel like oftentimes there's either hypoplastic or absent ribs at T12. So I personally place less weight on that if I can see the lumbosacral junction well. These other ones they talk about as being potentially other things you can look at. I don't really personally look at this coccygeal segment very often. And then the thecal sac they say should end at S2. I personally don't place a whole lot of weight on that either. Do either of you guys look at those two?
I do use the thecal sac because one of my neuroradiologist colleagues told me to do that also. So that's like a third thing I do. And when they're all discordant, I'm just like, it's probably normal.
Yeah.
As long as it's like a low lying sacral dimple, like closer to the anus, I definitely will bias my read based on what the indication for this study is. I should also say that.
And then just to run through some examples of each of those. So this is the nice pano, which I think shows all of those things nicely. So this coccygeal segment, we can see it just starting to ossify. So we can say this is probably S5 and then coming down. So this lumbosacral junction, we usually, hopefully if you see this nice angulation, then you can say that's probably the lumbosacral junction. And then S2 is about where the thecal sac ends in this patient. So just demonstrating to those. These panoramic views, I think, are really helpful in identifying where the conus ends and helping us see some of these things. It can be difficult to acquire in some patients if they're wiggly, but I think if you can get a nice pano, it really adds a lot to the examination. Counting from the ribs, we do have this as part of our protocol, so we count from both the right and the left ribs. So like we talked about, this can be variable. It's not that uncommon that we'll have different numbering, even counting from the left and right ribs if they have an absent rib just on one side. But this can be kind of an additional kind of secondary thing you can look at. This radiopic marker, I'm kind of curious how you guys approach this also. So this is, oftentimes our sonographers will, especially in cases where there's kind of discordant numbering, they'll reach out to us and say, do you want me to place a BB and do a radiograph? We actually have as part of our ordering system that there's a spine x-ray that gets ordered alongside of every single spine ultrasound that gets ordered. So it's kind of at the discretion of the radiologist whether we want to activate that order or not, but it makes it relatively easy that we don't have to reach out to anybody to get an order or anything like that. But I'm curious about how you guys think about these BBs and if you find them helpful, or how you guys approach these at your institutions.
I have only done this maybe once or twice in the setting of vertebral anomalies. But the good news is usually there's an x-ray either before or already ordered for after our spine ultrasound. Like the spine ultrasound is ordered with their midline workup sort of order set. So usually I've only once had to place a BB to like go from the ultrasound from the conus level to the x-ray. It's fascinating that you guys have it with your spinal ultrasounds, that it's like that commonly done.
Yeah, I was wondering, like, how often do you activate that pathway? Because I mean, just from I don't think we have that established here or where I worked formally, but and similar to Judy, I don't think I've ever requested it all that maybe once in my whole career. So it didn't seem like I needed it as much or as frequent.
Okay, that makes me happy because it's very variable. So some of our radiologists love these and get them on almost every single spine ultrasound. Like, this one is pretty, I would say, very normal. So the conus looks at it, it's kind of lower L2 or L2, L3. So I like in a case like this where there's no concern about, segmentation anomalies, or there's no concern about the conus position, I don't see that the x-ray adds a whole lot of value. But like I said, some people in my group really like these and they do find value in them. Like you guys, I personally very rarely will request to kind of activate that spine radiograph. Sometimes we have, backdrol patients or patients that have weird segmentation anomalies that, the spine ultrasound is the very first imaging they have done. And if they haven't had an x-ray already, then I might request it in that scenario. But the vast majority of the time, I agree, I don't find a whole lot of value in these. The other kind of facet in these is that I really don't know how accurate our BB placement is. So, a lot of these patients, we're scanning them prone and they're kind of curled up in a ball sometimes when we're doing the spine ultrasound. And then we take them over to do their spine radiographs and their arms are above their head and they're totally stretched out and they have all this gel on their back. Like, I'm not sure how well that BB really stays in place and how accurate the kind of correlation is. It's not infrequent that we think the conus is in one position on ultrasound and then it looks like it's totally different on x-ray. So I personally don't know how accurate they even are, but so I think the BB itself, I personally don't find a lot of value in, but I think for segmentation anomalies, it can help just kind of figure out exactly what's going on. So I'm glad that you guys are on the same page about that with me.
Sounds like a great study that you could do.
I know, I've had it on my mind for a while.
With all your free time.
Yeah, I know we have so many of these, like we have hundreds of these radiographs that we could look at with ultrasound, or we have the ultrasound and the x-ray. And, I think it'd be interesting to look at those two with MRI and kind of see how well they correlate, but I don't think they're going to, but I'm very curious it's on my list of things to do.
Yeah, I like it. I want to see the true utility in it.
Yeah. Yeah, I was looking yesterday because I was curious if there'd been studies on the correlation between MRI and ultrasound. And actually, it was pretty high correlation. I think it was like 96% correlation for conus position between ultrasound and MRI, which I think is, matches with what I see in clinical practice. But I'm going to do it at some point where I'm going to look at these two.
Yeah. I wonder if the discordance, is it because, it wasn't seen too well on ultrasound, or I wonder where the cases of discordance came from.
Right. Yeah. Yeah. So next thing I wanted to talk about is, what do you consider to be a normal conus position? So I was also kind of just interested because as I was gathering cases for this talk, this is another thing that I noticed a fair amount of heterogeneity in my group about when people request an MRI, what people consider to be a normal conus position. So I'm curious what your approach is as far as what you consider to be normal and when you request further imaging versus when you just pass it and call it a normal conus position.
I think it depends who you ask, but lately what I've been going with is if the conus is below the upper 1/3 vertebral body of L3. So if it hits or is below that level, I call it abnormal. I know next you're going to ask about preemies, and I don't have a great answer for that one either.
Yeah, I go by the upper end of L3. So it's interesting that you go a little bit lower.
So do we all agree that L2-3 vertebral disc space we can call normal regardless of age? But that's where I've noticed some discrepancies. Some people in my group will call L2, L3 as at the disc space as either borderline low, or they'll just call it low lying. But I personally consider that normal. It sounds like you both agree with considering that to be normal.
Yeah, I think it's allowed to go to the level of L3.
Okay.
Yes.
And then with preemies, do you give them a little more leeway as far as going to the L3 vertebral body?
I do, and some of my colleagues will recommend a follow-up ultrasound closer to term. I really have stopped doing that because they're always normal on the follow-up, I feel like.
Yeah.
Um, I know these are cheap and easy tests, but they're not that cheap. So
Yeah. So if it's a preterm infant and they're like upper to mid L3, you'll just pass it and not recommend anything specific.
yeah, now if they're like super low lying, I will definitely recommend a follow-up or even an MRI if it's super low. And
Okay.
depending on the clinical suspicion, like, an atypical sacral dimple or something like that, and I will more often recommend an MRI rather than a repeat ultrasound.
Yeah, and I think I'll talk a little bit more about it. I think in those scenarios too, it's also just important to kind of closely interrogate everything else, just making sure there's make sure there's good cord motion, make sure there's no tract or anything like that, make sure there's no abnormal soft tissue. But I agree, if it's all of those things look normal, if there's no really concerning secondary findings, then I'm similar that those L3 preterm infants, I'm okay with just passing those.
Yeah, I do have a question regarding like that, assumption that the younger or the preterm infants may have a lower lying conus. But now we have a lot of prenatal imaging, like especially prenatal fetal MR. So I wonder if there's been any studies or something that just looks back and say, hey, we looked at all these non-tethered kind of cord patients, and this is where it truly lies. Like this is the lower limit.
Yeah, and I remember there is a small paper that talks about kind of the normal ascent of the conus. I don't remember the details.
I think
of
that's an ultrasound, right? Postnatal ultrasound.
Yeah, but I think what I'm thinking of, they talked about even like in 16 to 20 week pregnancies, it was at like L4. So I think that must have been with either with MRI, like fetal MRI maybe.
Oh, or like OB ultrasound or
Yeah,
something.
yeah. But I think like in those really early kids, they can be at L4. And like obviously we don't see those in clinical practice after the antenatal period. But I think, in those really early babies, it starts at L4. And then I think it makes sense, like if they're at 30 or 34 weeks or whatever, that it would be at L3 and then kind of continues to ascend. Yeah, so I think that's at least my understanding of it. And then this was just kind of an illustrative case. So this was a preterm infant. So the conus was right about the L3 level. I have this little cine clip here. Should replay if I have my pointer out. Let's see. So it just really shows that nice cord motion there. And then patient had a follow-up MRI at term equivalent, and we can see that conus is ascended a little bit. So I think that just kind of highlights kind of the point we were making, is that oftentimes these follow-ups end up being normal. So as long as there's no secondary findings, then like we talked about, I think we can generally just pass those patients. Next kind of protocol component, I'm curious what you guys do to document nerve root motion. So this is, again, a little cine clip just showing, we personally obtained these both in longitudinal and transverse, just showing that nerve root motion. Some places talk about using this M-mode imaging as well. We tried this for a little while, but we personally didn't get a whole lot of value out of it beyond the cine clips. Have either of you guys tried this, or how do you guys document nerve root motion?
The same as your first mention, like just cine clips in the transverse and long.
We actually just do sag cines, but we get it twice. Once where we go from the rib medially, and then we'll get a second sagittal cine like stopped on the, like just with our transducer still. I'm curious, Jeffrey, if you guys then charge a B mode, when you were, I guess it doesn't sound like you're doing it anymore. Were you charging an extra B mode?
We were not.
I'm sorry, M mode charge.
Yeah, we did not do any additional charge for it. But yeah, I kind of thought maybe it would be interesting to look at the kind of like the amplitude of the motion and see if that had any correlate with cord tethering. A lot of these babies, it's really hard. Like if they're just completely asleep and motionless, like a lot of times there's pretty minimal cord motion anyway. So I don't know. It was just one step for the extra step for the sonographers, and we probably did it for about a year, and I don't think we really found a whole lot of clinical value in it. So we ended up not doing it anymore. But some places we'll talk about doing this, but yeah, we're back to just doing the cines as well. And then as far as these transverse images, so we get 3 different transverse images. So we get one kind of above the conus, one at the level of the conus, and then one below the conus. I think this one above the conus is really nice just to look at the actual morphology of the cord. Thinking about, some of those like split cord malformations can be really difficult to see on the sagittal images. So they're very rare. So I couldn't even find any case examples that we had on ultrasound. So, but just gives you a nice look at the kind of distal end of the cord. And then these below the conus images, they really just nicely show all these nerve roots just kind of laying dependently within the thecal sac. I'll show a couple images where that was not the case in cases of cord tethering. So this is just a nice look at these nerve roots. They really should be laying along the dependent aspect of the thecal sac. And then decubitus images, we don't have this as part of our standard protocol, but this is just something you can add on for kind of some additional, if you want kind of a second look at where the nerve roots are lying. So when you place the patient on their side, if there's not cord tethering, these nerve roots kind of should again lay dependently along kind of the lateral aspect of the thecal sac. So it's, like I said, not part of our standard protocol, but sometimes radiologists will elect to add this on if they think it would, just give a second look at what those nerve roots are doing. And then next kind of controversial topic I want to talk about was filar thickening and what you consider to be a thickened phylum. So, historically it's been a 2 millimeter cutoff. It's what a lot of people talk about as what is considered too thick for the phylum. I know my number's really tiny on here. This was a 1.9 millimeter, and you can see on the MRI, there's this little bit of, fatty infiltration of that phylum. There was this paper that came out a few years ago that kind of revisited that cutoff for what we should consider to be a thick phylum. So I'm curious what you guys have done about this. So this particular paper says that 1.1 millimeters is a more optimal cutoff for looking for filar lipomas. So have you guys implemented that, or what do you consider personally to be an abnormally thick phylum?
We still use 2 millimeters. I don't know. I don't know is what the right answer is. I feel like the 1 miller, I think is 1.1 millimeter cutoff, maybe is just a little bit too sensitive.
Yeah.
I think I rely more on like other findings. I know motion can still be normal, even if you have a little bit of fatty infiltration of the phylum, but we haven't lowered our threshold just yet.
Yeah, I'm the same. I think we still use 2 millimeters, and I haven't read the paper for the 1.1. So I wonder if, like, neurologically, do these patients exhibit anything that requires intervening upon?
Yeah, that was my biggest concern about using this lower cutoff is, are we identifying too many that are clinically insignificant? Like I know that I read like in autopsy patients, like in the general population, like 5 to 6% of people will have some fat within their phylum. So, is it really benefiting these patients that we're identifying these potentially asymptomatic ones? So I agree. I'm not really totally sure personally what to do with this. I think it's good to be aware of, but again, like you said, Judy, I think really just kind of taking this in the context of the bigger picture. If you have a little bit of a, phylum like this one that's, 1.8 or 1.9 millimeters, everything else looks totally normal. Maybe that's just clinically insignificant. So probably a little bit more work needs to be done to figure out, like you said, also high tweez, what the true, clinical impact of identifying this is. But yeah, I think it's tough to know exactly what to do with that. All right, so just talking about a couple normal variants as well. So I think as far as just, knowing that these exist and not calling these pathologic, not recommending further imaging for these, just kind of being aware of these. So this is the kind of so-called pseudosinus tract. So when we see this dimple, so a lot of these, I think I get the sense are patients that probably did not warrant imaging screening to begin with. If they have this really low dimple that's very close to the coccyx, that could be considered a simple dimple, and again may have not needed imaging in the first place. But personally, I'm kind of reassured when I see that the dimple has this little kind of hypoechoic tract that goes right to the tip of the coccyx. So this just can be considered. I really want to just make sure that we take a close look at this, make sure that it truly is not in communication with the thecal sac. But one like this is so far away from where the thecal sac should be. So if you see this, I personally find it reassuring as far as there being any true pathology elsewhere, but just being aware that if you see that little tract that goes to the coccyx, that's considered to be this so-called pseudosinus tract. Likewise, this ventriculus terminalis. So this is kind of this, just a little bit of fluid within the distal aspect of the central canal. I'm curious, do you guys even mention these, or what do you guys do with these?
I mentioned them in my findings, but not in my impression.
Yeah,
Agree.
yeah, I agree also. And I think that, just being mindful of how patients interpret these, now that they can see all of our reports, even if they see something that's normal, that can still be concerning for people just because it's not something that another kid might have. So I think that's anxiety inducing for a lot of parents. So I am the same. So I will mention it in my findings, but really not try to draw a lot of attention to it. And then do you guys, for this particular finding, do you have cutoffs, like internal cutoffs for where you consider this to be normal versus if it's really dilated where you might raise more concern about it?
I always have to Google the measurements. It's like a few centimeters in length, I think, or maybe it's a couple vertebral bodies in length. I always have to go look that up.
Yeah.
I should have reviewed before this. Did not.
Yeah, I think that's right. I think it's 2 centimeters in length is considered to be. I remember reading that somewhere. Yeah. So, but I have a couple cases later where we'll see that the length is not that long, but it looks like it's a little bit, the width is a little bit wider. So I think that there's somewhere it's a little bit confusing. I think other cases or what we've mentioned, that this really has to be taken in the bigger clinical context, but as a completely isolated finding, like we talked about, I think downplaying this is the right thing to do. And lastly, filar cyst. So then again, very classic appearance is this little cystic focus right at the tip of the conus and the proximal aspect of the phylum. So I, again, consider this just to be a normal variant. I treat this like the other things we talked about, just kind of bury it in the finding, just mention it. I think, some people in my group don't even mention these at all. I think that, if a clinician looks at the images and they, see that, the sonographer measured it or, took extra pictures of it, and then we didn't mention it, I think sometimes they'll, think what's going on there. But I think I personally at least will just mention that it exists and just kind of downplay it in my findings like the other things we talked about. All right, so a couple of cases to review. So I think that one thing I want to emphasize, I think it's really easy to kind of get in the weeds on these. There's a lot of very kind of complex malformations that can occur in the spectrum of neonatal spine imaging. Like I talked about before, I think I just want to emphasize that most of these patients that have abnormal findings will go on to have MRI. So at least as far as ultrasound goes, we definitely want to make sure we mention all the pertinent findings, but as far as actually fully characterizing these, I just think that we need to recognize that pretty much all of these will go on to MRI. So like I said, can be very complicated, but we'll kind of focus on a few of the pertinent findings. So first case here, so we'll start off with the conus position. So really not much ossification in the coccyx, but I think we can potentially identify the lumbosacral junction as being right here. This is one where it's not the most obvious transition. It's a little bit kind of this little curve here, doesn't have that nice angulation to it. But I think this is probably S1, L5. So that puts the tip of the conus at about the kind of lower L3. This is one where we just kind of pointed out and kind of have that kind of borderline filar thickening about 1.5 millimeters. On our transverse images, so we can see that on this patient, we did both transverse and decubitus images. So we can see that the nerve roots are pretty much identically positioned on both of those. So there's no dependent layering of those nerve roots on either of these images. And then on the cine clip here, there's a little bit of motion, things are wiggling around just a little bit, but I don't get the sense there's a whole lot of, everything just looks a little bit tighter to me than it should be. So this patient went on to have a MRI. So again, just demonstrating the low position of that conus. I have this T1 image just demonstrating in this particular case that 1.5 millimeter phylum did not have any associated fatty infiltration of the phylum. But this is a case of tethered cord. But I wanted to just briefly discuss kind of how you word these. I know Judy, we talked a little bit beforehand about kind of wording and that tethered cord being more of a clinical diagnosis. In a case like this, would you use the terminology of tethered cord in your report, or how do you kind of report these out as far as terminology?
These days I say low-lying conus and like any other things associated, but I don't actually say tethered cord anymore because again, one of my neuroradiology colleagues said, hey, can I talk to you real quick? So I stopped using that terminology in my reports.
Yeah, I've since adopted like a overall philosophy similar to yours, on a lot of things, not just tethered cord, but I try to now be a lot more descriptive, and then, only like give like a true like impression or like diagnosis if it's something that's like really helpful or pertinent. But yeah, like, torsion, detorsion, lots of discussions on different things that I no longer say in my report, and tethered cord is one of them.
Yeah, I think it's definitely fair. The other thing that kind of came to my mind when I was thinking about this was like nutcracker syndrome. We see that all the time where we have that kind of compression of the left renal vein with the kind of proximal dilation. And some people will say that to call that nutcracker phenomenon unless they're symptomatic, and then you can call it nutcracker syndrome. I saw something similar. Some people call this tethered cord syndrome once they actually become symptomatic, but that's not something necessarily that we would be always know that information when we're dictating these. So I agree with both of you. I think it's wise to kind of be descriptive, tell people what they need to know as far as what imaging features are present. But I think wise to be kind of careful about precisely what words are used in a situation like this. Right. Next case. This was again an infant. This is a 22-day-old that came in with a sacral dimple. So again, this is a patient that kind of has that coccygeal ossification center, so we can count from there. So 5, 4, 3, 2, 1. So lumbar sacral junction we have a little bit more clearly defined in this particular patient. So the tip of the conus is again about the L3 level. This is the patient also that has this kind of cystic dilation of the central canal distally. I didn't measure this one, but this is kind of one of the ones I was questioning. And I think it's probably less than 2 centimeters in length, but kind of just looks weird with how wide it is anterior posterior, especially with these other findings that are present. And then if we look at the dimple, so it looks like the dimple does have a communication with the thecal sac itself, kind of at the level of the lower lumbar spine. So this patient went on to have a MRI. So again, we can see that low position of the conus. The MRI, the actual morphology of the tip of the conus looks a little odd. Looks a little bit more well-formed on the ultrasound. I think like we've talked about in some other sessions, I think that the resolution of ultrasound oftentimes could be better, especially in some of these younger patients where they're potentially moving around. But overall, kind of the tip of the conus looks a little odd in this particular patient. Then we can see that kind of hypointense tract going down into the communicating with the thecal sac there. So this is the case of a dorsal thermal sinus. And have a companion case just to show you kind of the other entity that exists on the same spectrum. So this is a patient that was born with kind of this macular lesion on the lower back with this little kind of divot in the center of it. So on ultrasound, the spine numbering, I think, was a little bit challenging in this particular patient. I think on MRI, we'll end up seeing this patient this was more of L6. So the tip of the conus was kind of at the L5 level. And then on our additional imaging, patient had decubitus images. So we can see again, between these transverse images between supine and decubitus, all of those nerve roots are pretty much the exact same position. This is an M-mode image just showing that there's really not a whole lot of motion anywhere in the cord. And then again, we can see that dimple that extends down to the level of the thecal sac, kind of near the level of the lumbar sacral junction. So the patient went on to have an MRI, which pretty much shows all those same findings. So conus terminates at the level of L5. We can see that tract kind of extending down to communicate with the thecal sac, kind of in the lower sacrum. So this ended up being another entity called limited dorsal myeloschisis. So this is even on the MRI, our neuroradiologists included both this and dorsal dermal sinus on the differential. I think this is really, at least especially on ultrasound, I think would be very challenging to differentiate those two. But again, just to kind of make everyone aware of this entity that this exists, these are kind of the two main things that exist in the kind of general category of these sinus tracts. So limited dorsal myeloschisis and then dorsal dermal sinus. So next case here, so we'll talk about a couple of cases of caudal regression syndrome. So this is a 3-day-old was known to have sacral agenesis. So on our panoramic image here, so you can tell that not the best quality, but you can see that there's really not a whole lot of ossification down at the level of the sacrum. We can see some of the lower lumbar vertebral bodies, but really not a very well-formed sacrum. That correlates with our radiograph where it looks like very truncated. This is just kind of a zoomed up image of the conus, which looks very high in position, kind of has this very rounded, kind of abnormal, blunted appearance to it rather than a normal kind of triangular shape to the tip of it. So this is a case of type 1 caudal regression. So if you have a kind of a truncated cord with sacral hypoplasia. So again, this just shows pretty much the same findings that we saw in ultrasound with that very kind of high and blunted appearance to the tip of the conus, and that's dysplastic sacrum. Then the other entity that exists on that same spectrum, so this is again, a case in our panoramic image. We can see some of the sacral vertebral bodies, but a very abnormal appearance to it. It kind of has this abnormal undulating contour. I think it's very challenging to say what level this conus is at. We tried to do a radiograph on this patient, but it has very unusual numbering of the vertebral bodies. So I had, I think, 13 ribs on the right, 12 on the left. Had all these segmentation anomalies. I think challenging to actually say where the tip of the conus was in this patient. This is again just showing that discussion we had about the phylum. So this, I know that number is super tiny. It's about 1.8 millimeters for the thickening of the phylum. I think this also kind of highlights, I personally have a hard time in some of these cases where there's not a lot of CSF to actually define exactly where the phylum starts and ends. I think this is a pretty close measurement, but sometimes those nerve roots are so squished around it, I think it can be hard to measure. But overall, kind of very abnormal constellation of findings in this patient. So MRI again shows very similar, kind of this very abnormal contour of the spine with this kind of sacrococcygeal hypoplasia. This patient did end up having a fatty phylum. We can see that little bit of T1 bright signal there, low position of the conus. So this overall, some low-lying conus, that kind of fatty thickening of the phylum, and then sacrococcygeal hypoplasia. So this was in the spectrum of a type 2 caudal regression. So next case, again, a patient with a sacral dimple. So again, I think this is a little bit challenging to count all these sacral vertebral bodies. I think the lumbosacral junction is probably somewhere transitions right around here. But again, the actual tip of the conus, I think, is really difficult to discretely identify. There's kind of this cystic dilation of the central canal and the distal cord. There's all of this abnormal soft tissue within the distal end of the thecal sac. Very closely associated with the kind of neural placote of the distal cord. Closer imaging of the tract of the dimple, so we can see that it does extend down to communicate with the thecal sac kind of in the lower lumbar spine. And then MRI correlate, again, just showing very similar imaging findings. So we can see that the spinal cord itself has all this kind of cystic dilation of the central canal. We can see all this abnormal fat within the thecal sac, again, very closely associated with the distal end of the cord. We can see that abnormal kind of hypointense tract kind of extending, communicating with all that. So this was kind of in the spectrum of a lipomyelocele. So this is one more case just to discuss as well, but just wanted to stop there for a moment. Again, this is just kind of showing the kind of spectrum of imaging findings that we can see with ultrasound. Again, just emphasizing that I think the most important thing is really some of those things that we talked about before, kind of really defining what's a normal or abnormal conus, what the nerve root motion is, all those kind of things that are really going to help us decide whether a patient needs an MRI or not. You know, in a case like this one, you know, the ultrasound is so abnormal. I think it's less important to get every single thing right about exactly what's going on, because, you know, that patient is definitely going to get an MRI. But I'll stop there for a moment and see if you guys have any other thoughts on, you know, just your kind of general approach to spine ultrasound, or kind of just if you have any other thoughts on that.
Yeah, I think it is kind of like essentially a screening like test. And so you just want to be sensitive enough to pick up like which kids should go, you know, further on. Because I mean, like you said, a lot of these kids might need it anyways. And then some might require sedation. So I think my biggest thing would just be like, okay, this kid truly does need something, and sedation's warranted. Like that would be my deciding factor.
Sure. All right, and then my last case I wanted to discuss was, this is kind of a different realm of what we talked about, but more of these kind of congenital abnormalities, but this is a kind of more acquired issue of these patients that get these spinal hematomas after failed lumbar punctures. Judy, thank you for sharing these cases with me. So the top left image, so we can see all this kind of abnormal echogenic tissue within the extraaxial space with kind of some mass effect on the distal aspect of the thecal sac. And this is a separate patient. We can see this little bit of air within the thecal sac, also related to a lumbar puncture. So I just wanted to briefly discuss kind of general approach to these as far as, when they're performed, what the overall kind of utility of ultrasound in this particular scenario is. I had, shared with you too previously that, we in Colorado, this is really not very commonly, if ever, done. I know there's some places that very routinely do these. I know there's some places that, after a lumbar puncture, they'll do daily ultrasound to kind of follow the blood and make sure that it's resolving and see when they could potentially try a lumbar puncture again. I'm just curious to hear from you two, kind of what's your overall kind of approach to at your institutions, how spinal ultrasound is used in these particular scenarios.
I guess at CHLA, I don't think we do it too frequently. And then for when I was at Texas Children's, I think it was done more frequently. So we did do quite a bit. And Judy, I know you guys do it too. And I don't know if you guys have like an age limit. I mean, we can all agree like the younger baby is going to be easier to see. But I feel like at Texas Children's, we did even for older patients. I guess the only limitation I truly had was how big the patient's, back or subcutaneous fat is, because whatever that the linear probe can penetrate, like I could try to see in between the spinous processes, even though the whole posterior elements are fused. But I don't know what your experience is.
We mostly just use it at the request of our interventional radiology colleagues. And the question is not typically, is there hematoma or is it resolving, but is there enough CSF that they're going to be able to successfully get a sample? These are almost always the infants less than 30 days of life that need the whole workup for that when they present with fever. So almost always these are those patients for us. Obviously the image guidance, like ultrasound, spine ultrasound to help with chemo injections and stuff like that are my IR colleagues do that for us, thankfully. But yeah, the case with the air was only a couple of weeks ago and I had never seen that before. I had to Google the term for that. It was, I can't even remember. It was like pneumoric arachitis or something like that. Just Google pneumo air in the spinal canal. I had never seen that before, but that was after a lumbar puncture attempt. And apparently that's the most common etiology of that is iatrogenic, but then also post-traumatic causes of air. I'd never seen that before. It was crazy looking.
Yeah, definitely very interesting. I'm curious if you try to differentiate, just 'cause I don't have a lot of experience with these, do you differentiate where the blood is in subdural versus epidural, or how do you define that? Does it matter?
I think for the purposes of what we're looking for, it doesn't matter. It is always extradural. So it's not involving the quarter rootlets itself. I think I always have to look this one up too. Mitch Reese actually has a great review article about spine ultrasounds, and I find myself referencing that more than I should. At some point, these things should stick in my brain, and they just don't. Yeah, I just will say extradural, hematoma, and then talk about if there is or is not a lot of CSF visible.
Cool. That was my last case I have. I know we have a few minutes left. If we have some time for discussion, if anybody has any questions. Is there anything else that anybody else wanted to discuss in the realm of spine ultrasound? Anything else that you guys think would be worth discussing?
If it's okay, Harris Cohen gave us a couple of comments in the chat that I would love to share because he's got incredible experience. Just on our discussion of using plain films to help with the conus level, he says they stopped using it many years ago. But if there's any confusion, they will get an x-ray, they tape the BB really well and get prone imaging x-rays for the x-ray confirmation, which I think that's a good idea. I had never thought of that.
Yeah, that's definitely interesting to think about,
keep the baby in the same position
as much as possible. That makes more sense than how we're currently doing it. So
well, except almost always when we do a spine ultrasound, the mom or caregiver, whoever that person is usually holding the baby just to make them comfortable. So obviously we couldn't do that. But yeah, the other thing he says is he uses the top of L3 as normal, but the literature includes through the mid L3 level. And then for the fatty phylum measurement or the filar thickness cutoff, he thinks that getting measurements that small reliably would be challenging.
Yeah, that's
I
definitely a
agree
fair
with,
point.
it's like less than 1 millimeter.
Yeah, that's definitely a fair point. It's just the inter-rater reliability is going to be very limited. Just when you're talking about measuring things that small, like 1.1 versus 1.3 millimeters, we're
Yeah.
able to accurately measure that. It's gonna be a challenge for sure.
Yeah, especially because I always tell my residents round up to the nearest,
Yeah.
millimeter, and this is like, don't do that. The other thing one of my techs told me when I first started here, that I think is actually super useful is when you're getting that panoramic view, go from like the anus level caudad to cranial, and sometimes there's a little bit less motion. I remember going superior to inferior, the babies give you like a little shimmy almost, and so your panoramic is like wavy. So, we've had some success doing that.
Oh, interesting. Yeah, I'm not sure if our techs have a standardized way of doing that. I'll have to ask them, but yeah, that's definitely interesting to think about. And then one other question I got was if we image simple dimples that are greater than 2.5 centimeters from the anus. So we actually don't even really know, like, they just order these and then we image them. So oftentimes we don't really have a whole lot of clinical information about exactly where the dimple is in relation to the anus. So we end up imaging them if they order them. I don't know if you guys kind of screen them a little bit more closely than we do, but
we tried to, so it was members of radiology, neurosurgery, the NICU, and the neonatal, like newborn nursery people. We tried to get together to come up with like ordering guidelines, and we got to a set of creating them, and it sort of fell through the cracks around COVID. And it was really hard to get all the neurosurgeons on board with not screening these low-lying, close to the anus sacral dimples, which are probably mostly just coccygeal pits, right? Like no relation to spinal dysraphism whatsoever.
right.
But that'll be something we have to take up eventually. Maybe when the neurosurgery, my neurosurgery colleagues like switch, have a little bit of turnover or something like that.
Yeah. All right, so I don't have anything else in my chat, so I think we can go ahead and wrap things up there. This may have been the paper you mentioned, Judy, which I'll point out you're also one of the co-authors on. So it's definitely a great paper. Definitely recommend anybody reading this if anybody wants more details about anything we talked about today. Definitely a lot of great information, and especially about all the kind of like deeper details about embryology and all those types of things. So definitely take a look at this if you're interested in more details about what we talked about today. But otherwise, we'll go ahead and wrap up for today.